Very good morning, everyone, and warm welcome to today's weekly session of the Society for Health Research and Innovation webinar series. Today, we have an excellent topic on our hands. It's peripheral vascular disease principle of management. It's both an honor and pleasure to introduce today's renowned expert in this field of vascular and transplant surgery, Dr. Aruna Weerasuriya. Dr. Aruna is a consultant vascular and transplant surgeon and a senior lecturer in the Department of Surgery at the Faculty of Medicine, University of Canada. His distinguished training includes vascular fellowship from Fiona Stanley Hospital in Western Australia. And he has already specialized in, done the experience on the specialized registrar at the Royal Person Hospital at the Lancashire in United Kingdom as well. With an academic background that spans from MBBS to MD as well as to MRCP, Dr. Weerasuriya brings a wealth of clinical and academic insight into the evolving principles and challenges of managing peripheral vascular diseases. Today, he will guide us through the key principles of diagnosis, interventions, and long-term care for the patients with peripheral vascular disease, highlighting both evidence-based practice and surgical perspective. So, without further ado, please join me in welcoming Dr. Aruna Weerasuriya to deliver today's presentation. Over to you, sir.
Thank you, San, for your kind words of introduction. So very good morning to everyone, those who have joined online. And today, within the next 45 hours time period, I'll be getting you through the peripheral vascular disease and basically the principles of management and how you would exactly manage a patient when you get this kind of thing. So before I get into the talk proper, so I'll just get to one of the case scenario just to get some insight as to what you should do in this kind of patient. So these are common situations, and if you happen to work in surgical wards or maybe perhaps in the OPD setup, you might come across these kind of patients coming to you day by day. And this is one of very common presentation. You see this 55-year-old man who had presented with the painful right to sort of blackish discoloration for a few weeks, actually more than 2 weeks. He's known to have diabetes and has had non-STEMI about 6 months ago. And on examination, there was absent foot pulses on that side. And the foot was found to be swollen and the toe appears dry but smelly. So at this stage, a few questions I have in my mind to put you through. And so, do you know about any clinical diagnosis by now? Second question is whether you carry out any toe amputation, and in your GP practice, if you happen to practice in general practice as a general practitioner, would you just wound care and manage the patient by yourself? And will you start any antibiotics? And their last question is, what kind of treatment is ideally indicated in this patient? So at the end of my talk, I think you should be getting good insight to the actual problem of this patient and should be able to answer all these questions. So these are my education objectives for you. So you need to understand the term PVD, that's called peripheral vascular disease, and its clinical spectrum, which includes intermittent claudication and critical ischemia, or which sometimes we perhaps known and call it as limb-threatening ischemia, or CLTI, chronic limb-threatening ischemia. So we need to review the diagnostic approaches and stratify the risk involved in these patients and the management, and to evaluate the medical, endovascular, and surgical options available to deal with this situation. So as you know, the peripheral vascular disease, even though we call it peripheral vascular disease, it's not really peripheral. It is one of the spectrum of presentation of the arterial disease, when you actually call it a peripheral vascular disease, we generally attribute it to peripheral arterial disease. There are veins also, there are lymphatics also getting affected, but we are not going to talk in detail here, but mainly focusing on the arterial disease. So even though as I talked, so it's peripheral artery disease, it's one of the presentation of multisystemic disease. Generally, it is the process is due to the process of advancing age and all, due to accelerated atherosclerosis, and that leads to blockage of arteries and leading to the clinical manifestations. So it's not only happening in the peripheral arteries, but can happen in cerebrovascular arterial tree and also coronary arteries, which I'm not going to talk here today. So the occlusive artery disease, which is further a better term as occlusive artery disease rather than peripheral artery disease, because it's occlusive artery is an umbrella term, peripheral artery is one of the, under that. So, and the chronic limb ischemia. So when you call peripheral artery disease, it can involve acute problems and chronic problems. We generally attribute here into chronic problems, which is known as chronic limb ischemia. So here my focus of talk today is mainly talk about the chronic limb ischemia associated with peripheral artery disease. So with the advancing age, as you know, the world population growing older, but due to the advancement of the technology, medicine, and everything, so world population aging, and so is the diabetes, incidence of diabetes, hypertension is also rising exponentially, and people who do smoke also carry on large scale, not our part of the world, but when you go to the West, so they smoke quite a lot. So because of these problems, so the atherosclerosis is actually getting very enhanced to the point it can occlude the arteries. I talk about the epidemiology. So you see about 0.2 billion of the world population out of 7 billion has affected this kind of problem. So prevalence-wise, 3 to 12% of general population will be affected in a given population. So it's really a problem of old age. As you see, those who are older than 65 years of age, there's a prevalence of up to about 20%. So 1/5 of the world age over 65 is having the disease. And diabetes is another problem. So there is a rise in diabetes, and even in our part of the world, in Sri Lanka, the incidence of diabetes is about 30% of general population. So you see, out of those who are diabetics, there's about 30% prevalence of peripheral artery disease in this population. You see the global prevalence here. You see the this graph shows two different factors. This, which is on the first two rows in the graph, is showing high income groups, whereas the right two actually represent the low income groups of the community. So these low income group countries have high incidence of peripheral artery disease compared to the Western or high income population. The other thing is these are known facts from United States done about 25 years ago due to a study. So you see, but these are still valid. So you see, until up to about 60, so the incidence of the PVD is quite low, is actually running less than 3%. But when it goes beyond 60, the incidence rising very rapidly up to about 60%. So as you see, after age of 50 and so on, 60, the male gender is predominantly affected. But if it goes beyond 70, the female gender is actually getting affected more than the male gender. I presume it's basically the process of atherosclerosis getting accelerated after the menopause of females. So that is why patients, for females, having more high chance of having atherosclerotic disease. And the other problem is the ladies are such that their arteries are quite small compared to male people counterparts. So as a result, even if you have a small amount of cholesterol deposit in your arteries, so you get the clinical appearance is enhanced. So clinical percentage is quite severe. So dealing with these kind of patients is not that easy compared to male people who have large arteries. So just to brush up your anatomy knowledge, so you see when you talk about the peripheral artery system, so in the lower limb, I'm basically focusing the lower limb here. So you see the aorta, which is the largest artery, which is divided into common iliac artery on either side, and common iliac artery again divided into two arteries. When it crosses the inguinal crease, which is when it in the pelvis itself, it gives rise to internal iliac artery, which supplies the visceral structures in the abdomen and so the buttock region. And once it's given its internal iliac artery, it's called an external iliac artery. When it crosses the inguinal crease, so inguinal ligaments, we call it common femoral artery. And then it goes to two arteries, the deep femoral artery, which is also known as the profound artery, supplying the thigh muscles. And the continuation of the same common femoral artery is known as superficial femoral artery. When it goes beyond the popliteal region, that's behind the knee, we call it popliteal artery, and which is again going to divide in three main segments. Actually two. It's one is the anterior tibial artery, which is the communication down to the foot, which is called as dorsalis pedis artery in the foot. And then the next artery, which is there as a single trunk, which is called tibio-peroneal trunk. And tibio-peroneal trunk actually divides into tibial artery, posterior tibial artery, and peroneal artery. The peroneal artery actually doesn't supply much to the foot, but the posterior tibial artery, the counterpart to dorsalis pedis, supplies the back of the heel. And so anterior tibial artery and posterior tibial artery are the most determinant factors supplying the foot, and which makes a communication within each other and having good anastomosis and collateral supply. So the peroneal artery, these are three arteries: tibial arteries, which is also known as tibial arteries beyond the popliteal artery, quite small in caliber, and dealing with these kind of arteries once a disease is quite challenging. So in terms of the vascular disease, we generally divide these areas into three different regions. Up to the groin crease, aorta and iliac arteries are there, so we call it aorto-iliac segment. And then the femoral artery downwards up to the popliteal artery, from groin crease to up to the knee crease, which is called femoral-popliteal segment. And then we have tibio-peroneal and tibiopedal, that is supply beyond the knee level up to the foot. So these are technical terms we generally use in terms of the recognition and also for the therapeutic access and procedures. So if you talk about pathophysiology, it is actually the atherosclerosis is the main culprit. But mind you, atherosclerosis is not the only thing which is affecting the peripheral arterial system and causing disease to present. I'll tell you later, there are other conditions, but mainly the main focus is the atherosclerosis. And the atherosclerosis, once plaque deposited under the intima, you see the cross section of the artery, the adventitia, media, and intima. The intima in the vessel is the most precious part of the vessel. It maintains the homeostasis. Due to lipid derangement, dyslipidemia, and other risk factors associated with atherosclerosis, you get plaque form subendothelially. So these plaques once form, you see now on the right-hand picture showing the plaque actually gains the lumen, whereas the white happens is because the lumen is the least resistive pathway for the plaque to develop. Whereas the other way, it's not possible because the adventitia and the outer layers and the muscle layers very thick. It doesn't allow anything to expand that direction. As a result, the lumen is the only one which is going to suffer. Until up to about 70% of the lumen is compromised, you don't develop any symptom. So that is the most important thing. Even if you have any significant atherosclerotic plaques inside your body, it is not clinically manifested. So because these issues, because until up to 70% of luminal compromise, you are compromised, you are actually maintain the flow without any problem. And once you get the clinical manifestations, you develop different problems. I will let you know later on as time goes on. So the plaques, there are two things can happen to the plaques. One thing is the plaque can actually build up gradually, and it can actually occlude the lumen with the gradual deposition of cholesterol material, leading to complete occlusion and cut off of the blood vessels, blood supply beyond the territory. The other thing is the plaques, there's a plaque has the capsule. The plaque fibrous caps can actually rupture and leading to the extrusion of the cholesterol-rich material into the bloodstream. Once it's extruded into the bloodstream, these materials are highly thrombogenic. It can actually cause intense thrombosis of the artery at that time, at that side, and leading to the complete occlusion. That's what's happening in the coronary arteries now. That's why you get heart attacks, MI. And the same thing happens to the legs also. So once the plaque ruptures, it can lead to intense thrombosis and occlusion of the artery down the leg and leading to what is called as acute limb ischemia. But if it just embolizes the rich material, it can actually sometimes, if there are large particles, it can embolize down the stream, leading to the occlusion of the artery down the stream, including the smaller vessels. So, which is known as trash foot, sometimes clinically manifested as a small digital gangrene, sometimes patient develop. So these are the clinical manifestations. If it just gradually occlude in the arteries, so it can lead into the a gradual development of peripheral artery disease, leading to what is known as intermittent claudication, or later on, which is known as critical ischemia, which I'll explain to you later. So these are the risk factors and pathophysiology for the patients to develop this condition. There are major risk factors and minor risk factors. The major risk factors are the advancing age, the dyslipidemia, the hyperhomocysteemia, hypertension, diabetes, smoking. So these are major risk factors. Hyperhomocysteemia is a minor factor, except the dyslipidemia, high cholesterol level in your body, mainly the low HDL and high triglycerides and high LDL levels. These are the very bad combinations patients to have. So the additional risk factors or minor risk factors are family histories, chronic kidney disease, inflammatory conditions. So because inflammatory condition I have mentioned here, because it is known that if you have high CRP level, it is one of the strongest risk factor to develop peripheral artery disease. And the hyperhomocysteemia and high fibrinogen level, they are all associated with peripheral artery disease. There are social determinants like socioeconomic status, like our part of the world now, so Sri Lankans have increased incidence of diabetes and other peripheral artery disease going hand in hand. But there are genetics involved, and the distribution of the disease pattern is quite different from the nations to nation. I'll explain to you later. And there are problems in healthcare access and environmental factors, and so on and so on. So this graph shows you about the risk factors, how strongly they are affecting the disease process. You see history of cardiovascular disease, and these are very high in prevalence with these kind of patients because, as I said, this atherosclerosis is one of the peripheral multisystemic disease. And so it jolly well involves the coronary arteries and leading to ischemic heart disease in these patients. So dealing with these kind of high-risk cohorts are quite challenging. I will let you know that as I go along in my next few slides. So high HDL is actually protective, as you see in this graph. So if you have high HDL level, those who are having athletes maybe doing exercise regularly, there's a protection against this. And high CRP is again risk factor. Smoking is another strongest risk factor, and which is if you are current smoker, which is very high risk of developing peripheral disease. But if you are stop smoking, still you are at a high risk. But for you to develop the background risk or to reach the background state of risk after abstinence of smoking, it takes about 10 years. So even if you stopped for a few months ago, so your risk is still the same, perhaps at a slightly lower level compared to the general population. So hypertension and high BMI is another risk factor. If you're low BMI is another protective one. Male gender and age after 10 years of age. As you see, this graph shows you as time goes on in your age. So this is the disease of old age. Okay. And these are the clinical spectrum of the disease. So you see, a majority of these patients are asymptomatic. So about 50% of these patients having asymptomatic disease, because as I said, until up to a 70% of the luminal compromise, you don't develop any symptom. So, but they have the disease. The disease can manifested if you have foot wound or any traumatic wound. Once it start not healing, so then the problems arise. But on its own, without any wound or any other problem, the clinic is basically clinically silent. So the once they develop significant atherosclerotic plaques, so develop intermittent claudication, which is again about 1/3 of the population cohort of these patients. And finally, you develop chronic limb-threatening ischemia. As the term itself says, it's a limb-threatening. So there's a very high chance of limb amputation of these cohorts compared to those who are having independent claudication only. So, and the other spectrum is acute limb ischemia. You see now I said about the cholesterol plaque, sequel plaque, once it ruptures, it can lead to the limb ischemia acutely due to plaque, the sudden occlusion of the artery. So these are the clinical spectrum of presentations. And so when you generally talk about chronic limb ischemia, which is part of the occlusive artery disease, rather peripheral artery disease, when the limb perfusion has reduced significantly beyond 2 weeks time frame, you call it chronic limb ischemia. So acute limb ischemia is definitely less than 2 weeks duration. So I have represented the sequelae here in greater detail and what happens. But the two varieties, what happens in chronic limb ischemia are the intermittent claudication and critical limb ischemia. Mind you, there are varieties. Sometimes you might not get any of these clinical spectrum presentation. There are atypical or less atypical presentations. As you see in this gentleman who has a plantar foot wound, which is not healing. And if you really check, there's no pulse, but he has no pain. And so the only problem with him is the wound, which is on the plant aspect. He's walking on it and he doesn't have pain. So these are mainly due to neuropathy, associated diabetes, and neuropathic ulcers. And so this is another variety in the diabetic neuropathic patients. So this is intermittent claudication. You see the picture in the right-hand side. So this is Claudius in Greek mythology. This man, is a ruler, had been limping when he was walking. So he had walked quite a certain distance and then he stopped and touching his calf muscles and then he start again. That's how it happened. And the term really derived from this patient's name, Claudius, claudication. So which is intermittent. So he walks and stops, walks, stops. This is what it is. It is a reproducible pain happening in particular muscle groups. Not only the calf muscle, it can happen in any of the leg muscles. So commonly it affects the calf muscles. I'll explain to you later about the site and all. But the term itself is cramping pain brought about by exercise, relieved by rest. The resting time is usually 2-3 minutes and less than 2 minutes actually. And certainly less than 10 minutes. If it goes beyond 10 minutes of resting time, it is not claudication, intermittent claudication. And and it is reproducible. When the patient walks the same distance, patient get the pain, and then he stops. And predictive at the same distance. So he can, if somebody is trying to walk about 50 meters, he can walk the same distance again once he relax for a few minutes. So this is what you need to understand. The history is most important than anything else in the diagnosis of this patient's conditions. See, now this is a graphical presentation of the patient's problems. You see, patients start walking here in the right upper corner, I have shown you. Then patients develop pain and then stop, and then again patient's pain relieves and start walking again. See, so if you talk about the anatomy and the disease associated with this condition, you see if the aorta and the iliac arteries are involved, so if the aorta is involved, say there's a occlusive disease in the aorta, so you get bilateral leg symptoms. So it is happening in the internal iliac artery and the whole lower limbs, both sides. So you can get buttock muscles getting affected and thigh and calf muscles. So you get to buttock and thigh claudications. So if they are common iliac artery affected, so you get a unilateral problem only on one side, and then the internal iliac artery is affected, so they get a calf thigh claudication. In addition to that, you get the buttock claudication. The other thing is that if the aorta is involved, there's internal iliac artery bilaterally affected, so the penile artery is also supplied by one internal iliac artery in both sides, so you get the impotence as a clinical manifestation in addition to the buttock claudication, so which is rather termed as Lerici syndrome. So this is another spectrum of aorta getting involved in both sides, internal iliac arteries. So the next one is if the common femoral artery is affected, the plaque is developed in the common femoral artery. You get the profound artery and the superficial femoral artery in the thigh affected. So you get the calf and thigh claudication, no buttock claudication. So if the artery is affected only in the superficial femoral artery, once it is given the deep femoral artery or the deep profound femoral artery, the manifestations beyond that, so it's just the popliteal artery getting ischemia, popliteal artery getting reduced blood supply, and the calf muscle getting affected. So they get the calf muscle claudication. I hope that's clear. So this is again elaborating you about the things happening there. So the clinical manifestation always beyond the level of occlusion or stenosis. Mind you, there are other diseases which can really mimic intermittent claudication. So one of the other varieties which is called neurogenic claudication. The neurogenic claudication can happen due to either nerve root compression or maybe spinal canal stenosis. The nerve roots can get affected due to the disc collapse, or perhaps if the disc, you see in the given disc, you have the nucleus pulposus and annulus fibrosus. The nucleus fibrosus can dislodge centrally or maybe laterally into the nerve root. That can actually impinge on the individual nerve root. So actually these patients may be manifest as sciatica. This is what is known as. So these patients have chronic back pain and they get pain while walking also because individual nerve roots getting irritated when the patients walk. And but this is atypical. The pain is actually not really getting relieved within 10 minutes. That is the maximum patients will experience pain when they have ischemic pain. But this is different, that their leg pain will not be relieved after 10 minutes. That will go on sometimes perhaps to about half an hour, maybe 1 hour. Sometimes patient will tell you that patient's pain is still there even they try to walk after half an hour's rest. And these patients usually need to sit somewhere for them to relieve the pain. Whereas those who have intermittent claudication, they don't have to sit anywhere. They just, what they do is they just walk still, stand still, and then try to walk again. So these patients are different. Spinal stenosis is another variety. If I have spinal canal getting narrowed, maybe perhaps due to the disc prolapse, central disc prolapse, or maybe the spine, the vertebra slips one or the other. which is called spondylolisthesis. So because of these two varieties, so the spinal canal get narrowed. As a result, so they get a sort of ischemic pain in the spinal cord due to that the patient develop pain in the legs. So again, it's characteristically these patients will experience more pain when they try to walk downhill, because your vertebral canal getting straight when you want to walk downhill, whereas when you climb uphill, the vertebral canal get open up. You have to bend forward for you to climb uphill. So as a result, spinal canal getting open up, so the pain get less. So which is the other way around when it comes to intermittent claudication, because you exert your muscles to a great extent, the ischemic pain getting worse when you climb uphill. But here, of course, the other way around. So this is the spinal stenosis and the characteristic problem, but they also have other neurogenic symptoms. Sometimes these patients will have paresthesia and numbness in lower limbs. They have muscle fasciculations. Sometimes this pain will be there in the night. They can have back pain. So you need to ask these all details from the patients before you come to a conclusion as this is intermittent claudication or this is a neurogenic claudication. It's very easy to understand if you ask few questions from the patients. Mind you, this is is basically a clinical diagnosis. No imaging is required for you to make a diagnosis. I have seen some people request Doppler studies, even sometimes CT scan to diagnose peripheral artery disease or the neurogenic, but that is not required. This is purely a history-based analysis and the examination findings. And the other problem is musculoskeletal pain. Those, you see, this peripheral artery disease is a disease of old age. These patients are the ones who suffer musculoskeletal disease to a great extent compared to younger population. So these patients will experience degenerative pain or maybe inflammatory pain. A degenerative pain is characteristically getting worse towards the evening, whereas inflammatory pain is getting worse in the morning hours, but less towards evening. So these are the two varieties. So you need to ask whether really pain is attributed to muscle groups or maybe the joints. So you need to ask whether these patients have osteoarthritis, where there are, if you really check these patients, they will have swollen knees and the ankles, so they have other arthritic diseases manifested. So this is a really mechanical pain, not really a particular muscle group pain. And the other thing is sometimes when you check, they will have foot pulses felt well. The third category is the venous claudication. The venous claudication is actually clinical manifestation due to deep venous occlusion due to DVT and all. So the deep veins are the ones which carry bulk of the venous blood. And once the deep veins are occluded, the superficial veins are the ones which carry rest of the blood. As a result, there is an impedance of blood flow back towards the heart when somebody is standing and trying to walk. So as a result, there's venous pooling of blood when somebody is standing, and it's a bursting type of pain. And there'll be tightness of the legs. Sometimes there's get swollen legs when somebody is standing and trying to walk. This pain getting less when somebody is keeping the leg up and trying to relax. So this patient needs some sort of elevation of the leg for them to relieve the pain. So that is venous claudication. They also experience pain during walk, but walking distance is quite short. They get bursting pain, then they stop walking. So I hope that's clear. There are three other varieties you need to clarify and exclude before you make a diagnosis of intermittent claudication in these patients. So there's a clinical classification system. There are two classification systems. One in common use would be the Fontaine classification, which is very easy to understand. The other one is Rutherford classification. For your practice, you can go by Fontaine. So there's always clinical diagnosis, clinical based categorization. You see, stage 1 is actually a asymptomatic variety. Stage 2A, mild claudication. 2B is moderate severe. Generally, mild claudication attributed to claudication distance of more than 200 meters. The moderate is less than 200 meters of claudication distance. So 3 is actually ischemic rest pain, which is the other counterpart, which is the advanced stage of disease. And the stage 4 is ulceration gangrene, which I will explain later. This again showing the same thing, but in more illustrative manner. So when you get these kind of patients, you need to take good history out of these patients because history, as I said, is the most important part of the diagnosis. And all the other imaging and examination are going to supplement your diagnosis. So age, of course, you are asking gender and all, and you need to ask clearly about the presenting complaint, which is really the pain or maybe the non-healing wound, maybe any blackish discoloration, which is known as gangrene. So you need to ask about the history of the presenting complaint once the patient tells what exactly the problem. So you need to elaborate more on the history of presenting complaint and ask what the pain looks like, whether it's really a pain brought about by exercise, or it's just really a pain which is even there at night or at rest. So this is a very detailed history you need to ask. And if it is non-healing wound, ask about the duration of the non-healing state. If it is beyond 2 weeks, it's anything which is not going to heal. So any acute wound will heal within 2 to 6 weeks time frame. But usually if it goes beyond the projected time of healing, potentially it's a chronic wound which is non-healing and is painful. So, and the gangrene, of course, is always abnormal. Somebody develops gangrene in toes, maybe in the foot or wherever, is always abnormal. There are problems such as the gangrene, so need to deal with that later on. And their family history. There are some of the patients will experience family histories, strong family history. Those who have dyslipidemias and all, and they have a strong family history of PVD in these patients. And social history, importantly, their social habits are important to us about the smoking habits, whether they are current smokers or ex-smokers are the most important part of this management. And then about the income, of course, sometimes, most of the time, these patients are poor socioeconomic backgrounds, so they don't have much money. And even though they smoke not cigarettes, sometimes they smoke locally produced, so BD and all, too. So these are very common in practice and among those who are poor. So that's also very strong risk factors. See, when you examine these patients, you need to examine these patients' lower limb thoroughly on both sides. You need to expose the lower limbs right up to the groin and appreciate all the things in terms of inspection, palpation, percussion, and auscultation. Auscultation, of course, here we don't do much as in other medical colleagues. But here the inspection, you need to check whether there are any skin changes like dry skin, scaly skin. Sometimes you have loss of hair, brittle nails. These are all surrogate markers of limb ischemia. The skin blood supply is reduced. So color then maybe change maybe to sometimes dry, blackish discoloration, or maybe pallor will be appreciated. And there may be muscle wasting. So because of the poor blood supply to muscles start wasting. So on palpation, check the temperature. All this other thing you have to highlight is that always compare with the other side. So if somebody says a right hand foot problem, so always check with the other side and compare and contrast always the other side. That's more important than anything else because PVD may be bilateral. So, but the other side may be clinical silent, but it's not manifested. But on this one side is manifested, but they have underlying problem. So auscultation, obviously, you can check for any femoral bruise. If there's any, before that, you can get actually trill on palpation, and you can check for bruise in the femoral region. And the other test that you can do is Ankle-Brachial Pressure Index, which I'm going to explain later on in detail. And the other test, bedside test that you can carry out is the Buerger's test. You can elevate the leg to 45 degrees and check for any color change. The patient's kept in the lower position to 90 degrees so. And you can appreciate the pallor. If severe pallor is developed, then 20 degrees, which is severe PVD. So these are the Ankle-Brachial Pressure Index values. PVD is diagnosed, the BPI is as 10.9. The severe PID, which is known as critical ischemia, is defined in terms of if it is less than 0.4. And it is if the ABPI value is very large, like more than 1.4, it is abnormal. In that sense, we have to do toe brachial pressure index. We can apply the toe pressure cuff. and then I check the pressure in the toe, and the ratio is 0.7 normally. If it's less than 0.7, it's always abnormal. So this is how you check BPI. It is very easy to do. You check the cuff and the ankle and the best arm pressure. You check the best value and divide the one or the other, and normal value is 1. So if it is less than 0.9, it's abnormal. So in terms of management of the intermittent claudication, you have to manage these patients well in terms of medical management, because if you follow up 100 patients with intermittent claudication for about 1 year, if you follow up 100 patients, so only 1% will lose the leg. So there won't be anything happening to their legs. 99 of the people will not have any problem with the legs. But instead, they will die of heart attacks and strokes. There were 3 to 6% of these patients going to die due to heart attack and strokes. So they have to manage the risk factors more than the leg tissue in these patients. So you have to improve the functional capacity and quality of life in these patients by managing medical risk factors, and atherosclerosis risk factors need to be modified very clearly. So antiplatelets are the mainstay of treatment. So this is the only drug which is going to be effective in terms of reducing the cardiovascular mortality in large clinical trials. So there's a class 1 evidence. And the statins are also the same. So if you reduce your cholesterol with high intensity statins, so there's again the benefit is for the heart and the brain. So there's a survival advantage. So you can, if the patient hypertensive, you can start ACE inhibitors for the management of hypertension, and you can start giving phosphodiesterase inhibitor like cilostazol. Cilostazol is a phosphodiesterase 3 inhibitor, which is going to increase the cyclic AMP level in the muscle level, and it has a vasodilator effect. So it's going to improve the blood circulation in the arteries, supplying the muscles. In addition, it has antithrombotic effect, reduced platelet aggregation effect. As a result, this is actually beneficial. There's a symptomatic benefit patient can develop. The lifestyle modification includes smoking cessation, and you need to get in collaboration sometimes psychologists, psychiatrists in this management, because abstinence of smoking is not that simple to these patients who are addicted to smoking. It's very difficult. So there are pharmacological treatments available to support these patients. Those who are convinced and motivated, you can support with that. The buprenorphine is one of the medication we can introduce. So, and we need to control diabetes, and maybe a target HbA1c is less than 7%. And the foot care is important, because this patient should not get any wound, and if any ulcers in the leg. Traumatic wounds are the most important factors to be avoided, because these patients have reduced blood supply to the leg, but they don't have any pain or anything at rest. So once they develop any wound, that's difficult to cure on its own because of the reduced oxygen. So we need to tell them clearly to avoid any foot injuries. Always wear footwear when you walk inside and outside home. And regular screening is important, and there's a multidisciplinary approach in this time management. So lipid management, you reduce your LDL and through less than 70. We are giving high intensity statin therapy. So statins, if you give atorvastatin, you have to give 40 milligrams of statin per day. This has to be administered despite your cholesterol being normal. That's highly important to understand, because once you diagnose PVD, these patients, their cholesterol may be sometimes normal. You might appreciate sometimes their cholesterol level 150, 200, that range. But you need to give this statin, because it's not to reduce cholesterol only, but it is other beneficial effects of statin. In addition to reducing cholesterol, it has a plaque stabilization effect. It has an anti-inflammatory effect. So this is going to prevent the plaque rupturing and developing MI and strokes. So this is the benefit of a stroke. Otherwise, all of you should be taking statin nowadays because of the risk factors. So blood pressure control need to be targeted to maintain near normal level, less than 130/90, as in other people. So ACE inhibitors and ARBs are the preferred treatment in these patients. Beta blockers are preferably avoided, but there's a controversy about the use of beta blockers because beta blockers will constrict the peripheral arteries, but in practice, it is not really contraindicated. So the other one is supervised exercise program. So you need to go and ask the patients to go on a supervised exercise therapy. What you need to advise the patient is that you need to go on walking exercise every day. This is a recommendation is at least to go about 30-45 minutes per day of flat walking, minimum of 3 sessions per week. But if you tell this to our people, they're not going to adhere to this. But generally what I say is that you need to go on walking at least for 1 hour every day. Then only they will go at least half an hour's walking. So you have to get to the custom made to your thing according to your population. So you need to go on this walking exercise minimum of 3 months for you to improve the circulation, because once you start walking, so a few things can happen. So one thing is you actually generate new vessels beyond the obstruction, which is called neovascularization, and improve the circulation. But it takes time. So it takes about 3 months. So you have to keep on motivating these patients to gain benefit. And you can, in the meanwhile, you can start giving silastazole and they can get psychological symptomatic relief. And then, so what you can do, advice is you can start walking, and once you develop pain, you can stop. The basic thing is to go on walking for that time duration, despite the interval between. So these are the mainstay of treatment. You have to stop smoking, hypertension control, cholesterol control, antiplatelets, regular exercise, obesity control, reduce weight, diabetes control, and foot care. And the next variety I'm going to touch upon is the critical ischemia. There's a severe variety of the limb ischemia. So this is rather defined in terms of the intense forefoot pain, which is known as rest pain, and or maybe a tissue loss in terms of ulceration or gangrene. Gangrene can be actually 2 forms, either dry gangrene or wet gangrene in a patient with established occlusive artery disease. If you check the ABPI value is less than 0.4, that is the abnormal value. And so these patients are going to suffer quite a lot. They can't sleep in the night because of severe pain in the leg due to ischemia. They have leg ulcers, which are very hurting in the night, and they usually keep their legs down. And diabetic patients have different problem. They have neuropathy and other problem. They have increased predisposition to infections. So those who have critical ischemia with diabetes, another cohort, they have very high chance of leg amputations. Even if you delay treatment, a very high chance of rapid progression. And so which is better term in Wi-Fi scoring system. The Wi-Fi is actually born in ischemia and foot infection, which is an international classification system, very widely accepted nowadays. I'm not going to detail into this time here due to time constraint. So natural sequelae of critical ischemia is the 3 subgroups. If you follow 100 patients, so 40% of these patients will get leg amputation. 40% of patients will like revascularize if they have the luck to come to tertiary care center where the facilities for revascularization is available. So 40% limbs can be salvaged out of 100 patients, and 20% of patients are going to die within 6 months of the onset of the problem. So see, this is the gravity of the problem. So there's a very high mortality. So this is worse than even having the worst cancer in this world, which is pancreatic cancer and all. So we talk about 5-year survival of pancreatic cancer nowadays. But here, this is a 6 months survival. 6 months mortality is 20%. So these are the high risk cohorts we are going to deal. So gangrene, as you see, it's maybe a dry gangrene on the left-hand corner or wet gangrene. The wet gangrene, there is a Piolis infection, which is suppurative, which is smelly, discharging, foul smelling. And the other variety that should know the Buerger's disease, which is a subcategorization of the peripheral artery disease, which is exclusive seen in young patients less than 40 years of age, and also exclusively smoking. So having this problem, they will start developing digital gangrene and then sort of limb amputation. The primary pathology is inflammatory process associated with smoking, and if they stop smoking, the things will reverse. If they continue smoking, they will have like amputation and everything. going on, which is really a kind of a different etiology and pathology. So management of these patients actually depend on the immediate action. We have to give these patients suffering, as you see in the right hand corner picture, it's a patient suffering. So pain management important. The wound care is another thing which you can't do much for the wound care because the ischemia, the wound is not going to heal. The infection control is another one. We have to give antimicrobials. So we have to revascularize ASAP. So this is the best part of it because without revascularization, so 60% of the patients will not have any improvement. So 40% of these patients will have leg amputations. So the long-term strategy would be aggressive risk factor living in addition, like what we do in those who are having claudication. And if they have any other surgeries, they have to rehabilitate and amputation prevention. So if you are planning an revascularization, which is called revascularization, getting the blood supply back towards the foot, which has to be an inline blood flow, which is in uninterrupted blood flow happening right up to the foot. That is the whole idea of revascularization. So this is the algorithm to go by. So if you have clinical suspicion, we do a BPI in addition to the clinical examination. If the BPI is low in critical ischemia, you have to go for imaging and then do stratify the risk, and then treatment planning is done accordingly. The revascularization, there are two arms in revascularization. One thing is the bypass option. Other one is to go for angioplasty, which is a minimal invasive thing. So if you are planning these two options, so you have to have a roadmap as to plan this treatment. So roadmap is done by the duplex scanning or maybe conventional angiogram. It may be a DSA or maybe a CT angiogram. You can do MR angiograms. So these are all angiograms. So to delineate the pathology, that is a roadmap. So if you are constructing a house, you need to know where exactly the things are laid down, isn't it? So likewise, you have to have a map of the artery, which we have to plan it. So then only you can make any positive plan and carry out the procedure without any problem. So planning is the most important part of the revascularization. And even if you plan everything, but you need to see whether this patient can undergo this thing, any surgery or anesthesia. So if the patient is fit to undergo a surgery, so the best thing is to go for a bypass or other variety, which is very invasive. If the patient is unfit in terms of myocardial issues, previous heart attacks and all, so then best thing is to go for a minimal invasive techniques like angioplasty and stenting. So before you embark on these things, there are the preliminary tests that you need to do. You can do full blood count, blood sugar, lipid profile, and so on. Echocardiogram is important to check heart. So imagine you need Doppler scan. You can see the Doppler signals. There are phasicity in Doppler signal. So triphasic is the normal variety, whereas monophasic is the one which you're going to appreciate in critical ischemia. This is only one phase, which is in on systole, no diastolic flow. So this is a bedside test that you can see. Even this color Doppler, you can appreciate the plaque which is there in the artery and see whether what the flow look like. And you can do a CT scan. You can delineate the pathology very well. This is a reconstruction. So compute analysis and amalgamates all the CT cut sections together to form a picture like this. So you can get pictures like this, and really a nice one. And you can do what is called DSA, digital subtract angiogram, which you see, which is the real-time imaging that you see in DSA. We can do MR angiogram. So MRI is beneficial in terms of the arteries. When the arteries are calcified, you can't appreciate that in CT scan well. So in that sense, we have to go for MR angiogram. And there is nowadays we can do intravascular ultrasound. This is being practiced in Western world. We don't have that here. We can insert a probe into the vessel and then intravascularly and check for any lesions. So these are the way forward. So indications for revascularization are very straightforward. If there's limb-threatening ischemia, certainly yes. And if the patient is having claudication, but this is disabling to the patients, Yes, those are the only two varieties for revascularization. Otherwise, you should not embark on these invasive procedures which is very risky, unnecessary treatment. And so anatomical considerations to consider would be the lesion site, complexity, vessel diameter and length, calcification with burden, whether circumferential calcification or not, and the runoff vessel, whether any poor quality runoff vessel to put a bypass or any maintain the patency up to the foot. And of course, the patient factors matter quite a lot. Check for surgical risk of the patients and the life expectancy. So the patient is going to live for another less than 6 months or so. No point embarking on these kind of very invasive techniques. Then in that sense, best is to go for non-invasive, perhaps some minimal invasive techniques. Check for functional status. If the patient is bedbound, there's no, I don't know whether there's a real need of doing any revascularization or limb salvage procedures, because the patient are going to walk in this. So you need to consider these things also into considerations. And comorbidities also matter quite a lot. And this is TASC classification. It is the international classification system, which is known as transatlantic inter-society consensus, which you can actually have nice categorization of the disease severity depending on the location, size, and the degree of occlusion or stenosis. There are 4 classifying system tasks depending on the level: task A, B, C, and D. Task A and B is usually reserved for angioplasty arm, that is the minimal invasive arm, because it's a very minor lesions, whereas tasks C and D are reserved for for bypass options because they are lengthy lesions. So the endovascular therapy is a minimal invasive thing, as you know. So going for balloons and wires, gaining access to the artery, inside the artery, and very short duration procedures, short hospital stay, and rapid recovery. But it's expensive, not available in every hospital. So the endovascular first approach is usually done some of the patients, those who are high-risk patients with limited life expectancy. And this is what you should do: the minimal invasive opening artery like that, crushing the plaque outside and maintain the flow inside. And you can combine it stenting for these patients. Stenting can be done to maintain the patency of the artery, there are different stents available. There are drug-coated stent and all, but these are commonly being practiced in the among the cardiologists, because they put stents normally, because consequences are grave if you have restenosis. So because that reason, cardiologists are the ones who are practicing quite length in here. But we also do that, but they are very expensive. So this is what you see. This is aorta and common iliac artery. On the left side, common iliac artery is occluded right throughout the length. So we maintain a wire across the region, and however, we open with a balloon and then deploy a stent there. You can see the minimal invasive thing, and no need of any cuts in the groin. You can do percutaneously and maintain the perfusion like this. If you do open operation, you have to go midline laparotomy and big operation, so it's very invasive and high mortality. So there are nowadays we have something called atherectomy devices. So this is being practiced in Australia. So we actually, even if there's complete occlusion, there's like a turbo hog device which we actually can recanalize the whole artery tree with a turbine like a dream system. You can actually make a core of a vessel, even if the artery is mainly blocked. So this is the way forward. Atherectomy. And so indications for, if you talk about the thing, surgical revascularization. So there are different bypasses, options available: aortofemoral, depending on the level, femoral popliteal, popliteal distal. So veins are the preferred mode of conduit of choice. There are prosthetics also being used, prosthetic grafts. These are the pictures really we use with bypasses or other things. And these are real images of the pictures. So there's other thing called endarterectomy. If there is focal stenosis or occlusion, we can actually take the plaque out, which we usually do in femoral artery. We do that in the the carotid artery also, which is called carotid endarterectomy, which is very focal area of stenosis occlusion. So we can take the plaque out and make a complete recanalization if it is focal only. If it is very widespread disease, so obviously we have to do a bypass, a lengthy bypass. So this is the actual images, how you see, and once the bypass is done to the posterior tibial artery here, you see the inline blood flow to the foot. There are other extra-anatomical bypasses also. Other than anatomy, it can do fem crossover or axillary-femoral. You can take blood supply from axillary artery to the femoral artery. So for those who are having aortoiliac disease, very high-risk patients who are not suitable for open or endo. And if everything fails, there are other options available, which is called lumbar sympathectomy. Initially, we used to do it as a surgical method, lies in the lumbar sympathetic ganglion. By doing so, the arteries are dilated and pain get resolved. So there are nowadays we can do chemical ablation techniques. And these are the evidence from the trials done so far. So there are BASIL trial. The BASIL is standing for bypass of angioplasty in severe ischemia of leg, done in 2000, and also we have evidence from that. The bypass arm is doing well after 2 years of follow-up. That is the evidence gained from BASIL 1 trial. The BASIL trial actually can for infrapopliteal region. So the endovascular approach has been better in terms of infrapopliteal segment. The BASIL tree actually gone for any drug-eluting stents and balloons. So that is the design for femoropopliteal segment. The CAPRI trial is a medical trial, which is checking whether the clopid versus aspirin is better in terms of PVD. Clopid has proven slightly better in terms of action. Better compared to aspirin. The COMPASS trial in 2018 checked whether NOAC therapy, novel anticoagulants, rivaroxaban, in addition to aspirin. That has also proven there's a benefit in that. The Voyager PAD trial has shown you, once we have done revascularization, if you combine NOAC, rivaroxaban, in addition to aspirin, there's proven benefit. So these are the evidence, and these are the way forward in the future. The novel therapies like SGL2 inhibitors in cardiovascular protection, GLP-1 receptor agonist, and novel antiplatelet agent, anti-inflammatory therapies, whereas advanced endovascular therapy like intravascular erythropoiesis going to be in the future. They have covered stent, bioabsorbable scaffold. And so key takeaway message would be peripheral artery disease, as you all know, is a severe cardiovascular condition requiring comprehensive evidence-based management. The focus on both symptom improvement and cardiovascular risk reduction. So whatever you do, there's always a risk of this patient having getting heart attack even after bypass or angioplasty. So you need to really risk stratify this patient. We're going to benefit. After all, when you are going to revascularize and save a leg, patients, if the patient is going to die, there's no point in doing that. So core management principle will be early detection through systematic screening, aggressive risk factor modifications, and goal-directed therapy, and structured exercise programs, and revascular technique and multidisciplinary care team. At the end now, so you need to understand this and you need to answer these questions clearly. I hope that's clear. And clinical diagnosis is critical ischemia. And you don't do toe amputation here until you revascularize unless it's infected and smelly and wet gangrene. Should not carry out any toe amputation, because if you amputate this toe, the next toe to go is the adjoining fourth toe, which is also turning black in color. But if at least at this stage you can leave alone, so you can save that toe if you aggressively manage the ischemia early rather than late. And so this is what is treatment. And thank you. If you have any
Yes,
questions.
thank you very much, sir, for that insightful and enriching presentation on peripheral vascular disease and also about the principles of management. So there are many questions, sir, but due to time constraints, we will go for few questions, but do not hesitate that we will be sending you the answers. If you have logged with the same name, that we will be sending you the answers to the people who have sent questions
Sure.
here as well. And the link is now available. Please go to the link and please do fill the link duly so we can send you the certificates promptly. If there are any missing certificates, please do reach us once again, because you know that there are more than 500 participants are coming each and every week. So it's a little bit of struggle, but still we're trying to do our best. So if there are any issues, please do let us know with your emails, or maybe you can send those or the requests from the WhatsApp group as well. The link for the WhatsApp group is also in the chat box. If you or your friend is not there in the WhatsApp group, please join the WhatsApp group as well. So the first question I'm going to put up on you is, what is the place of platelet aggregation inhibitors in the management of peripheral vascular disease?
Yeah, platelet aggregation inhibitors are two forms. You can go for aspirin or clopids. So that is very beneficial. I actually highlighted in my talk about the value of aspirin. So aspirin has beneficial effect in terms of the platelet anti-aggregation effect because it's low dose aspirin. 75 to 100 milligram aspirin is indicated. And it has what's the beneficial effect of it is once the plaque ruptures, there's a thrombotic risk. So that rupture and thrombotic risk is minimized if you have platelet aggregating effect by aspirin. So that in large clinical trials, it has shown to be very beneficial, and in fact improves the mortality of these patients. So that is there's a survival advantage. So if the patient is intolerant to aspirin, like gastritis and all issues, so we can actually go for alternative clopidogrel. But clopidogrel, not the first line starting one. Aspirin is preferable because clopid has a lot of other issues with surgery and other things, and people are very afraid of clopidogrel. But you can certainly sometimes combine aspirin and clopid, some high risk population was right.
Okay, sir. And there's another famous question as well. Now, in the lecture, you said that all should take statins these days. So, would you mind just elaborating on that as well?
True. I just frank it because nowadays patients have a lot of risk factors nowadays, and our community populations, 30% diabetic patient, population having diabetes. So, in fact, all diabetic patients should be taking the statins. The statins have a lot of beneficial effect. In addition to the cholesterol lowering effect, which is known as in terms of total cholesterol may be lowered, and your HDL will be enhanced, and the LDL will be reduced, triglyceride will be reduced. So these are the beneficial effects of statin in terms of reduction of cholesterol. But in addition, the plaques stabilization effect is also there. So plaques, once they build up, there's a chance of plaque rupture. The high-risk plaques are called, which are vulnerable plaques, where there's a fibrous capsule, which is a very thin layer fibrous capsule, which is a high-risk plaque. If there's a large lipid core inside, which is a high-risk plaque. If there's an intraplaque hemorrhage, so that's another high-risk state of plaque rupture. So then, because the statins are having anti-inflammatory effect, so it will reduce and the chance of plaque rupture, and has a plaque stabilization effect. Because of these three reasons, I think statins are very beneficial. That's why I said everyone should be taking statins, at least a minimum dose of statin, because there are always high risk factors among our population.
Yes, clear, sir. And another doctor is asking, sir, about the Krippel-Trenaunay disease. Krippel-Trenaunay-Weber syndrome and Krippel-Trenaunay syndrome, are they the same thing? And can you please elaborate on that as well?
Krippel-Trenaunay syndrome is actually a different variety. It's actually not attributed to arterial system. It's attributed to the venous system. In Krippel-Trenaunay, what you have is the abnormal venous channels. There is always deep veins are going to be absent, and in the thigh basically. And then there are alternative channels leading to the venous drainage. It's not up the artery. So that is syndrome, which is combination of the symptoms and signs. There will be leg edema, there will be enlargement of the leg, or compared to the other side, the leg is lengthy. That's because there's organomegaly, and the leg is getting bigger, and because increased blood supply, there's artery-venous communications. in that. So as a result, more blood going to that side of the leg. And there are the lymphatic channels are different. So there's a hypopigmentation patches there. So that is a clippertrenone. So this
Okay.
is about the venous system.
Okay, sir. And another question asks that this middle this polyarthritis nodosa falls into PVD. If that is so, that what's the differentiation between the peripheral vascular disease and
Yes, so
also
I
the
actually haven't touched upon the vasculitis as part of the over the course of the PVD. Generally, 90% of the PVD is caused by atherosclerosis. That's what I have highlighted. But there are always vasculitis. Vasculitis is the umbrella term. Inside that umbrella, there are different diseases. One of that is the polyarthritis nodosa. Otherwise, Takayasu's arthritis. Other one is this the thrombotic arthritis, which is known as Buerger's disease. So these are all umbrella terms in the vasculitis. This also causing the PVD as part of the disease. So usually the polyarthritis nodosa affecting small to medium-sized arteries like renal arteries, so coronary arteries are medium to small-sized arteries, not the bigger arteries like a femoral artery or.
Okay, sir. And another question asks about the pain due to the varicose veins of the lower limb and venous claudication. Is it the same or is it different? And is it possible to differentiate clinically?
Certainly, the varicose veins are usually very common, isn't it? It's in a given population, 30% of patients having varicose veins. Only a minority develop symptoms, right? The symptoms would be like pain and swelling and itching, bleeding, ulcerations, or thrombophlebitis. Those are the symptoms variety. Whereas you asked for the chronic venous
The
sorry, was that
venous claudication, sir.
venous claudication? Venous claudication is defined in terms of the patients who have got deep vein thrombosis. Deep veins are occluded. And then you develop secondary varicose veins in order to drain blood back towards the heart, because the leg has perfusion made by the arteries. The blood has to return on along the deep veins mostly. At a given time, about 7 to 80% of the blood is drained to the deep venous system. So if the deep veins are blocked, the superficial veins are the ones which are draining blood. As a result, you develop secondary varicose veins. So that is a manifestation only. So varicose vein is a manifestation. So the claudication happens due to the impedance of venous drainage. So I hope that's clear.
Okay, sir. For the last question for today, sir, if you diagnose a patient with occlusive arterial disease, can we directly start antiplatelets on him in a GP level, or do we have to refer the patient to the vascular surgeon before starting?
Certainly. You have to start aspirin and statin at your level. You can,
That is
no
okay.
problem with that. But better to
Right.
start aspirin, not the clopidogrel.
Okay. Right. Thank you very much, sir. So we know that you are really busy today and we have taken some of your time as well. So thank you very much for this insightful, very informative lecture. And thank you very much for all the participants as well who's coming today and joining with Shri. So we hope you will be joining with us in the next Sunday as well with a very inspiring lecture such as this one. And also you will be partnershiping with us in the future as well. So
Sure.
thank you very much, everyone, for coming and joining with us. And sir, thank you once again for giving this insightful lecture. And we wish you having a great day, and we want to see you in the next Sunday in the same time in the early morning as well. Thank you very much.
Thank you, you too.